Hello, everybody. Happy holidays. Now, this is really not a telehealth presentation. Rather, it is our Christmas party. Wishful thinking, sorry. We are about to speak of the cluster that telehealth is about to become, quite literally. But for some of you, this will be a CLE session. Some of you, it's just a webinar. So in order to deal with the CLE stuff, I do have to read something to you guys. I promise this will be the only thing I'm reading. So good afternoon, or actually, yes, good afternoon. Today is December 22nd, 2024, and we welcome you to the Garfunkel Wild PC webinar, The Brave New World of Telehealth Post-COVID, What You Need to Know. Stacey, Gulick, me, and Kat will present this program. Stacey and Kat are both in the firm's telemedicine practice group. The content of this course is acceptable for both newly admitted and experienced attorneys. Please be sure you continue to stay connected on Zoom until the program concludes at approximately 1 p.m. Participants will be eligible to receive 1 CLE in professional practice. For the New York CLE attendance verification purposes, all course codes announced during the program must be recorded on the attorney affirmation and evaluation forms and emailed to Ivan Rodriguez. So a couple of things, just some more housekeeping. We have all of you muted just because with so many participants, it would get to be a little bit of mayhem for everyone to speak their questions, but you can put your questions into the chat. So you can type them and we'll monitor them. We might not deal with them until the end of the presentation, but feel free as some things pop in your head to just put the questions. We're happy to answer them for you. And also, finally, I'm going to announce this now and at the end. This presentation is being recorded, and we will be sending out a copy of the recording at the end of the presentation. So with that, let's get started. Okay, just some reminder definitions of things that we have not dealt with in a long time. The originating site for telehealth is the location where the patient gets physician or practitioner medical services through telehealth. So the originating site is where the patient is sitting. The distance site is where the physician or practitioner is located when providing the telehealth service. So just to keep those things straight, we are going to be discussing them throughout the presentation. Also, you know, when you're billing for these telehealth services, you are dealing with place of service codes, which indicates where everyone is located. So usually we see in telehealth a place of service code of either POS 02, where the patient is not in their home, or POS 10, which is where the patient is in their home. So just a little reminder so everything makes a little bit of sense as we're moving forward. Okay, pre-COVID, remember those days that were all sunshine, butterflies, and rainbows? At least that's my recollection. So in the pre-COVID world, don't know why my slide isn't moving. Actually, quick. Now you can. Yeah. Okay, there we go. So in the pre-COVID world, telehealth was recognized. We knew what telehealth was, but it wasn't super popular because there were a lot of rules that were just not practical. The patient had to be located in a certain place. Providers had to be sitting in a certain place. Basically, telehealth coverage under Medicare was limited to rural areas with a few exceptions. And a lot of the other payers followed the Medicare rules in regard to telehealth. Now, there were some things easing up, but it was still pretty restricted as to where and what was happening with telehealth. And FQHCs and RHCs were not authorized to be providers of telehealth services, but patients could sit there and receive telehealth, but they couldn't be the provider of the telehealth services. Also, it's not cool. We did see some movement towards having more telehealth services available. The states were starting to pass insurance parity laws, essentially saying that services provided through telehealth were the same, were reimbursed the same as in-person services where permissible. We saw widely different consent requirements. Some states required consent, some states required written consent. It was all over the place. Providers had to be licensed in the state where the patient was located, regardless of where the provider was located. And under federal law and a lot of state laws, An initial in-person visit was required before prescribing controlled substances. Now, for you non-lawyers, you're going to see a lot of references throughout. We're required to include those since this is also a CLE, but if you ever want to look up the rules, there they are. So then COVID happened. Good heavens, there was a big explosion. The world changed overnight. It's interesting, I was looking at my notes getting ready for this presentation, and I looked at what I had done 4.5 years ago on telehealth. And at that time, I was speaking about how to implement telehealth in your offices. And wow, has the world changed since then. I was looking at what some of the states spent in order to implement telehealth in their states. And it's like billions of dollars. Billions of dollars have been sent to change the world of telehealth, which I find to be super interesting. So what happened during COVID? Overnight, literally overnight, the federal government and individual states began issuing all kinds of waivers to allow people to stay at home and still continue to receive healthcare. But no one had the right platforms, technology, bandwidth. It was astonishing. New types of practitioners were suddenly allowed to provide telehealth services. For example, all of a sudden, physical therapists and occupational therapists became part of the telehealth world where that hadn't even been contemplated in the past. Practitioners could provide services in many states without having a license in that state, or some states just made it easier to get a license in that state. The patient and the practitioner could be located almost anywhere in the United States. Consent for telehealth could be verbal, and prescriptions for controlled, it would be nice if I could speak, prescriptions for controlled substances could be written without an in-person visit. So we saw like a complete change. Everything overnight changed. So with that, what we saw was this insane increase in the amount of telehealth in this country. I think something like 6% of Medicare used telehealth services prior to the pandemic. During the pandemic, that went up to like 60%. And now we're back down to, I think it's a little bit double, it's about 12%, or between 12 and 15% of Medicare patients use telehealth services. So we saw this sharp rise, a sudden fall, but it has never gone back to what the pre-COVID world looked like. So the whole point of this presentation today is to talk about where is telehealth today. So I'm going to let Kat talk a little bit about controlled medications.
So before I dive in, I just want to say, so we will be monitoring the chat while we're through this. So I just want to point out, if you can't, there was a link shared that will have some materials, including the CLE materials, but we'll also make sure that there's a copy of the presentation after the webinar is done for everybody that would like a copy. So
go ahead.
Yep.
Okay.
So here's a couple things which Stacey already kind of covered, but let's start with kind of the easy things first. So here is the recent great thing that happened with telemedicine. So as many of you know, on November 19th, the DEA issued its third extension to its temporary flexibility waivers for controlled substance prescribing. This was a huge thing because, as everyone knows, these flexibilities were set to expire on December 31st, and there was so much question of, this ability to access needed medications for so many people. What would happen? Would we revert back to the in-person requirement? So thankfully, even though a final rule had been in process and had been in process for months, it got to the point where the DEA acknowledged, along with Health and Human Services, that an abrupt end to these flexibilities would be an absolute nightmare, both to practitioners, but more importantly, and most significantly, to patients that were reliant on these medications. So the third temporary extension, thankfully, continues to allow the prescribing of controlled medications, even when there hasn't been that first in-person evaluation, as well as prescribing Schedule 2 through 5 controlled medications through audio-visual, so Zoom, Teams, those HIPAA supported audiovisual telemedicine platforms. And then also continuing to allow Schedule 3 through 5 narcotic controlled medications for the purpose of maintenance and withdrawal management for the treatment of opioid use disorder. Those specific circumstances can have the use of audio only telemedicine encounters, which again, this is super significant because for so long, many patients have been reliant on getting this access to much needed medication. So it's been a great thing that this has been continued. Additionally, the temporary extension is going to continue to allow practitioners to have a little bit more ease in their DEA registration requirements. So DEA practitioner or DEA registration is still going to be required for all practitioners in their home state. So if I'm a practitioner and I'm licensed in New York, I have to have a DEA registration in New York State. However, if I start practicing and dispensing in New Jersey, I'm not required as of now to have a DEA registration in New Jersey. That said, I am still required to be authorized to prescribe and dispense or administer controlled substances in both my home state, so New York, and the state that I am practicing in, New Jersey. So when, just because the DEA says you're not registered, practitioners still need to be mindful that they are compliant with the state's rules that they're operating in.
Let me just interject a little bit there. So for example, New Jersey requires a CDS registration in addition to DEA. So if you can have a New York as your home DEA registration, and you would need the CDS in New Jersey.
So one thing that I want to point out, So one thing that I want to point out is some clients have asked us, well, what about the proposed rules that were issued and in process? This extension, which extends these flexibilities through the end of 2025, doesn't take the proposed rules off the table. As many people know, the DEA received an unprecedented amount of comments in response to their proposed rule. It was nearly 40,000 comments. So part of the delay in getting to a final rule was sifting through those comments. Also, as everybody knows, we've just had a change in administration. So purely my own speculation, but I would imagine current administration punted it to the next one, that, let the new team coming in figure it out. And there may be some rule changes that come along, meaning that there may be an amendment to the proposed rule. We don't know that yet. We won't know that yet until the new administration comes in, but that's something that, may be coming down the pike.
I changed it for you, sorry.
So with that said, as mentioned, your DEA registration, your DEA prescribing flexibilities, you still need to abide by your individual state requirements. So what we have listed here, we're going to go through a handful of states, but these are just a snapshot. Please be mindful if you're operating in states that we don't talk about here, check in with your counsel to make sure that you're being compliant with those rules. So for example, in Connecticut specifically allows prescriptions for Schedule 2 and 3 non-opioid controlled substances only to be prescribed via telehealth only for the purpose of treatment of a psychiatric disability or substance use disorder. In other words, Schedule 2s and Schedule 3s in Connecticut can't be prescribed for other purposes. Maryland, however, says practitioners can prescribe controlled substances via telehealth, full stop, except if you are prescribing opioids for the treatment of pain or pain management through telehealth, your patient has to be in a Maryland licensed healthcare facility. Additionally, New Jersey says, again, Generally, 3 through 5, you can prescribe via telehealth. However, you need to still abide by Schedule 2 in-person evaluation requirements. Now, when you have a minor that's being treated for certain causes, practitioners can have parents waive that in-person requirement, but you have to proactively and affirmatively waive that requirement to prescribe Schedule 2 stimulants. That is the only exception in New Jersey. So every other Schedule 2 for every other patient needs to have that in-person evaluation first. So at the beginning of COVID, Florida had some requirements as far as prescribing, but in 2023, Florida changed their law to allow providers to use telehealth for the purpose of prescribing 3, 4, and 5 scheduled controlled substances. So long as, and this is in the law, so long as the evaluation via telehealth is sufficient to diagnose and treat that patient. While you're not required to necessarily know the patient's background or conduct a full physical exam, you have to make sure that the telehealth encounter is appropriate and to justify the prescription. Now, Schedule 2s can only be issued via telehealth for a very narrow set of circumstances. Your patient's being treated for a psychiatric disorder, or there's inpatient treatment at a Florida licensed hospital, your patient is in hospice, or your patient is residing in a nursing home. Now, New York traditionally required an in-person visit. And as Stacey recalls, and we had this at the beginning of COVID, DEA issued their waiver and New York said, that's great for the DEA, we still require an in-person evaluation. And there was a lot of misunderstanding and confusion. So New York actually issued a clarification waiver of sorts that said, for the length of time that the DEA is waiving their in-person requirements, we will too. And that has been updated, and they're continuing to hold to that waiver through this third temporary extension from the DEA. So for the time being, New York is also allowing a waiver of in-person evaluations through the end of 2025. Now, earlier this year, the Department of Health issued regulations that would permanently allow for practitioners to prescribe Schedule 3 and 4 controlled substances, as well as 5s, without an initial in-person evaluation, if the DEA allows it as well. So basically what these rules, which are still proposed, they haven't been finalized yet, is basically saying, we're waiting and see. We're waiting to see. We're going to see what the DEA comes out with their final rules, and then we will adjust our regulation and our requirements accordingly.
Okay, we have a couple questions here that I'll address real quick. So someone asked, can practitioners like dentists only require a license for Class 2 substances? How do the interstate compacts and prescribing regulations impact options to prescribe across state lines? So most of the interstate compacts, and we can check to see if there's any that are different, but most of the interstate compacts go to licensure. They do not go to the approval to be able to write prescriptions for controlled substances. What the leniency that Kat talked about for the DEA, without that waiver, you would have had to have a DEA license in every state where you practice. That is going away. You only need a DEA license now, or permit or certificate, whatever word you want to use, in your home state. However, if the other states in which you practice require additional certification, like the CDS in New Jersey, you still need to go after those. The Interstate Compact does not do away with that. So you don't have much leniency other than within the DEA. Somebody asked this question, about what about students who go to another state, that's not really how do you continue to prescribe? That's not really a question about prescribing. That is a question about licensure. And the rules currently, in general, we're going to talk about this more, is that you have, in order to provide services via telehealth, you have to have a license in the state where the patient is located. Now, there are some leniencies in some states. You would have to check the state that you're interested in working in without a license. But in general, the vast majority of times, you need to be licensed in the state where the patient is located. So that, I know everyone asks me this question all the time. I have to give you the legal answer, and that is what that is. Also, the question was about the various requirements related to prescription monitoring programs. Honestly, we are not really prepared right now to discuss those types of things. That is a little far afield for this presentation, but if you want to reach out to us, we can talk to you about that. Okay, so now that was controlled substances. Yay, looks like in a lot of situations we are allowed to prescribe without an inpatient visit, although again, some states are more strict, so you got to keep an eye on that. So now we're going to remote supervision. In the physician fee schedule that came out for calendar year 2025, CMS did adopt some permanent guidance or rules that are helpful for telehealth. We're going to see that they are doing other things that are not helpful, but a few helpful things. And one of them is that for incident 2, those things that have a PCTC indicator of 5, for incident 2 purposes, you can do the supervision of the auxiliary personnel via telehealth, the direct supervision. So direct supervision now includes remote monitoring as well as in person. In addition, services described by CPT code 99211 also can be supervised remotely rather than just in person. Everything else has to be direct supervision, meaning they have to be present. Oh, I'm sorry, I read this wrong. Direct supervision can be done remotely only through December 31st, 2025. I'm sorry. So that rule is a temporary, meaning we'll see what happens at the end of next year. So, but these easing of the supervision rules may be super helpful for some of you.
Right. One thing to add, so the reason why these specific, and there was discussion in the final rule, CMS took this position of these permanent exceptions because they considered these particular services to be low risk. They're typically done by auxiliary staff, and they don't typically require the physician to be on site to directly or to personally supervise. So that's why. They're still reviewing these other services. So that's why they gave, or at least in their commentary, explained we're extending it through December 31st, 2025. So there may be some additional things that may be added where they'll make permanent a remote direct supervision. So that's something that we'll be monitoring over the course of the next year.
So also in regard to graduate medical education, they are allowing in certain circumstances where you're doing essentially a remote service, the supervising physician can supervise the resident remotely. And that meets the requirements. And in GME lingo, we talk a lot about that the teaching physician has to be present for the key portion of the service. So if the service is remote, the physician can supervise remotely rather than requiring in-person presence. In addition, the ACGME, which for those of you that don't live in the world of graduate medical education, is the accreditation agency for these programs. So the ACGME also recognized the benefit of remote supervision. Each of what is called their residency review committees, or RRCs, which is there is one for each specialty, has come up with special rules that we don't need to go through. But for those of you that are interested, we included the link here. Each specialty discusses to what extent they will allow remote supervision.
So before we have 2 questions about remote supervision, and we may know this, you may have. Has there been any change in New York of the general supervision of a PA to permit remote supervision.
Well, the supervision of PAs has always been remote.
Yeah.
Yeah. That is, in order to supervise PAs, you just have to be available by phone. It's the general supervision requirement. So that wouldn't have changed. It was already pretty loose. If you're talking about incident two, Medicare is allowing for the incident two supervision. So if you're billing Medicare or any payers that recognize incident two, you can do it remote.
The other question that we've received is, does the incident two also apply to supervision related to anesthesia services, as there are complex rules related to CRNA supervision with a physician anesthesiologist?
I did not see any leniency in that supervision, and that's not surprising because that supervision is related more to, is there an immediate need to intervene in a case? So I wouldn't expect to see much leniency in that. So yeah, we did not see anything like that. Okay, patient consent to telehealth. Just a little reminder, so every state's a little different as to what consent requirements that they have. We just give some samples here to show you how the states are all over the place. I'm not going to go through each and every one, you can read it. But so in Connecticut, they require you to document. You don't have to have the patient sign anything because that's silly. But in Connecticut, you have to document that you had the conversation with the patient. Florida has no rules. In Maryland, it can be oral or written. Again, in New Jersey, there are no general consent requirements, but the Medicaid office requires for Medicaid patients that they get consent. New York, similarly, there's no general consent requirements, but Medicaid has consent requirements. OMH, OASIS, they have their own unique consent requirements. So it is a little bit of a struggle to keep track of all of them. Some people just go forward and say, it doesn't matter because some things require consent. We'll just have a conversation with the patient and document the consent. I think that's probably not a bad rule because these states are all over the place. And even the agencies, as you see, like in New York, are all different within the same state. Okay, as I promised, we were going to talk a little bit more about licensure. In general, states require that the practitioner providing the telehealth services is licensed in the state where the patient is located. But there has become increasing flexibility as to how that exactly happens, right? So, for example, Connecticut and New Jersey, you got to be licensed in the state. That's the way it goes. In New York, same thing, except that for speech and language pathology and audiology services, there are some leniencies if an out-of-state audiologist or speech pathologist is working with a licensed audiologist or speech pathologist. So then you can practice 30 days a year without being licensed in the state of New York. In Maryland, again, requires that the physician be licensed in the state where the patient is located, but they offer to practitioners the ability to become licensed through a very expedited process. Short, it goes really fast. So, sorry, that's okay. So then we see that in Florida, an out-of-state practitioner can register just to provide telehealth services. Can't have a bricks and mortar facility, but you can provide telehealth in the state of Florida. Again, this process of getting that type of license in Florida is much quicker. Kansas, wide open, says, hey, as long as you're licensed somewhere else, you can come practice here. In Pennsylvania, they also, like Florida, allow for these extraterritorial licenses. It's not, for Pennsylvania, it's not listed up just to telehealth. People can kind of come and go. And then finally, we have what is referred to as these multi-state compacts. We had mentioned this before. Basically, these multi-state licensure compacts allow for practitioners to more efficiently get licensed in multiple states all the time. And for some specialties, there are the concept of an interjurisdictional concept, which allows practitioners to use their license to practice in one state as the basis to practice in other compact states. So the interjurisdictional is kind of rare. I'm not going to go into that too much, but I'm going to comment a little bit about the multi-state licensure compacts. So when practitioners I know when these practitioners apply for licensure through the multi-state licensure compact, they must identify their principal licensure state. And actually, when I read the literature, the reason for that is to support IRS forms that must be completed, like when you do your taxes. So approximately 47 states, not New York, just for those of you who are on this call, approximately 47 states participate in varying degrees with these multi-state licensure compacts. And every specialty is a little different, but essentially the different buckets of the way they participate is some are saying we'll only participate in the multi-state licensure compact for those physicians that don't have their home state here. So say you're Virginia. I don't know if this is what Virginia says, but I'm just listing that state. So Virginia says anyone who's licensed here as their home state has to go through the regular licensure process, but out of state people who want to practice here as well through telehealth, we'll allow them to do the multi-state licensure compact process. So then some states say, yes, we'll be both the home state or the away state, we'll do anything. So you have to look at what your state's doing as to how you go forward to participate in the multi-state licensure compacts. And we listed a few here. Every specialty has its own compact, or a lot of specialties have their own compact. If a specialty doesn't have a compact, then you got to go the old-fashioned route and just get licensed in each state. Do we have any questions on anything here?
It doesn't look like it. No.
Okay. All right, we're going to go a little bit back to Kat for talk about the things that are now going to blow your mind.
Yes. So I have the fun section of, the concern that everyone has is all these waivers that are going away on December 31st. What does this mean? What's going on? Who's doing what? So here's kind of the big thing, but unfortunately, the not clear-cut thing that's happening that most providers are worried about. So as previously mentioned, so on November 1st, CMS issued its 2025 physician fee schedule. In it, it was very clear in the commentary for us legal nerds that read through all of the commentary. CMS was very clear about their limited ability to take any action. While they support extending all of the waivers, unfortunately, some of the bigger ones that we'll talk about really they don't have the authority, the legal authority to extend. It has to be done by some sort of legislative action. That said, to the extent they could extend some of these flexibilities, they tried to. So first and foremost, they made permanent the ability to use real-time, two-way, audio-only communication for any Medicare telehealth service. But the only way that's going to happen, and this is going to be, from here on out, they've made this permanent. You have to document that the physician or the practitioner that's providing the service is able to provide interactive audio video technology, but the patient in the originating site has either doesn't have the technology or ability to participate, or they do not consent to using audio video technology, and they only want to do it by phone. Now, for everything else, that's in a very narrow set of circumstances. But if the waivers from a legislative action perspective are allowed to expire, audio-only services are going to be allowed for a narrow purpose. So you have diagnosis, evaluation, or treatment of a mental health or substance use disorder in the home, or monthly end-stage renal disease clinical assessments. As of right now, it looks like what CMS tried to do, which everyone appreciates, is it doesn't really have a lot of teeth to it, because again, if these waivers are allowed to expire, we're going to go back to that very narrow set of circumstances. And all other, as I mentioned, all other use of telephone-only telehealth or audio-only telehealth is set to expire at the end of this year. So in addition to that permanent change that CMS attempted to make, we have some extensions through the end of 2025. So what will be a relief to practitioners are they will still be able to be home or be anywhere basically in the United States and provide telehealth services, yet still use their Medicare enrolled practice address instead of their home address when performing those Medicare services via telehealth. Also, CMS through the end of 2025 continued the suspension of the frequency limitations for inpatient visits and others.
Sorry.
No, that's okay. So here's where we're at. So CMS, as I said, made it very clear, we need legislative action to make this happen. Well, what's going on with that legislative action? Unfortunately, and as we were walking into this conference room to give this presentation, I was anxiously checking, hoping, beyond hope, that there would be some update as to what's going on with this legislation. So there are currently two bipartisan bills, the Preserving Telehealth Hospital and Ambulances Act and the Telehealth Modernization Act of 2024. Those would, the Telehealth Modernization Act would extend, it initially tried to permanently extend all of these waivers and say, this is just how telehealth is going to be from now on. However, it was amended to only extend these flexibilities for an additional 2 years or through the end of 2026. And then the Preserving Telehealth Hospital and Ambulances Act was just going to extend everything through 2026. Unfortunately, nothing has happened. The Telehealth Modernization Act was voted out of committee and onto the House floor on September 18th, where it has been patiently sitting and waiting and collecting dust. Unfortunately, as of right now, no vote is scheduled on the House floor. What would be required, and with 2 weeks effectively left in the year, this would require passage in the House, then passage in the Senate, and then would be sent to the president's desk for signature. There's hope. So let's, maybe there'll be something that happens between now and the end of the year. For the Preserving Telehealth Hospital and Ambulances Act, that was referred to the Subcommittee on Health in May of this year, where again, it's sitting patiently, waiting for someone to pay attention to it and collecting dust. So in both instances, these pieces of legislation are what would most significantly impact telehealth practice throughout the country. So if nothing happens between now and December 31st, starting January 1, all of these waivers that CMS, through its rulemaking activity that wasn't able to make permanent, that we talked about earlier, we're going to revert to pre-COVID requirements. So what is that? What's going to be go back into effect on January 1? Well, first and foremost, patients are going to need to be located in either a rural area or a health provider shortage area and be physically located in an eligible originating site, like a physician's office. We're going back to pre-COVID rules here. Also, during COVID, the rules had changed where it was any provider, any Medicare enrolled provider was able to bill for telehealth. Now, come January 1, it's going to go back to that list of eligible telehealth providers that we had pre-COVID, your doctors, your PAs, your NPs, clinical nurse specialists, your mental health counselors, and those. Basically, and most significantly, your physical therapist, your occupational therapist, and your speech language pathologist and audiologists are not going to be reimbursed anymore. So as we already talked about, audio-only telehealth is going to become a very, very narrow set of circumstances. And for many of our clients, this is going to be a huge impact. For non-behavioral telehealth services, FQHCs and rural health centers will no longer be eligible distance site providers. That's going to be a huge thing. But like I said, we're still hopeful that something can happen between now and New Year's Eve.
Yeah.
Do we have any questions or?
Yeah, we do have some questions.
Okay.
So I'm not sure what is the next slide, or is this a good spot?
Sure.
So the one is CMS limitation on a direct result of SCOTUS overriding the Chevron doctrine.
So I'll take that first. No. What it is that CMS is limited because these waivers that we're talking about here were part of a legislative act. Only a legislative act can extend them. So it's not a Chevron deference issue. It is just, who has the authority, and CMS doesn't have the authority to extend something that is in statute.
And I'm a little more cynical. I think CMS is like, ha.
They're
Just saying. Can you please repeat, as of now, 2024, are we coding televisits conducted from home using the provider's home address or our practice address? Will this change in 2025?
So the ability and the flexibility that's been extended is that a provider doesn't need to enroll their home address as a Medicare location. So when you're providing the service, you can list your enrolled practice site as the distant site location. You don't have to, even though you're sitting in your house, you don't have to enroll your home as a Medicare eligible location. So that's that continued flexibility.
Someone asked if a physician, for example, a gastroenterologist, performs consults with older, non-technically adept patients who cannot use synchronous video. Can a provider assume that these services will not be reimbursed by CMS?
So that's the hard part, because this goes back to CMS tried to make it permanent that if you documented that the patient, you were capable of doing the audio visual, but the patient either didn't consent or wasn't capable, that was a great attempt on CMS's part. However, it really, as we mentioned, it really doesn't have any teeth, because at the end of the day, come January 1, the originating site rules come back into play. So if the patient is home or not in an eligible originating site, then yeah, you're going to have some reimbursement issues.
We have a question as to best practices to prepare during this limbo stage where telehealth is a key function. Honestly, we don't know. Assuming that Congress doesn't do anything for the next 2 months, it is extremely limited what telehealth services, at least non-behavioral telehealth services, you can provide to Medicare beneficiaries and get paid for.
And one thing to point out, and it kind of flows into our next question, is this for reimbursement only? These waivers, and as Stacey will get to later in the presentation, these are for Medicare reimbursable services. So this is about payment. This is, you provide the service, but you're not, come January 2nd, you're not an eligible provider, or the patient's not an originating site. Medicare is not going to reimburse for the service.
Then explain the very narrow circumstances for audio-only telehealth.
Right. So again, and I may have just talked through this, but so as of right now, CMS is attempting to make permanent that you have a patient in their home who is either unable, so doesn't have the technology.
I don't think you have to go through all that. I think they want to know, when are you allowed to do audio? I think it's behavioral health and.
Oh, yeah.
Right.
Yes. So it'll be for behavioral health services.
And for certain renal function.
And
services.
for end stage.
Yeah.
It's for the diagnosement, treatment, or evaluation of behavioral health services, and then for end stage renal disease.
Right. Those are the exceptions that allow for audio.
Thank you.
Yeah.
Thanks for clarifying.
Yeah.
So, and just, I see meaning voice only. Yeah, audio only means voice only means the telephone. Audio visual is you're using Zoom or some way where you can physically see the patient as well as hear them in real time.
Do you want to do this one? Do you want me to do this one? You can do this. Okay. So there is a very narrow exception for certain types of kind of very mature ACOs. So ACOs that take two-sided risk and have selected a prospective assignment are actually allowed to bill for telehealth services. And these waivers, ending of these waivers doesn't affect them. But this is a super sophisticated exception, but one that is available for those ACOs that qualify. All right, wanted to comment a little bit and emphasize that all of the things we have been discussing about the waivers going away is not pertaining to behavioral health services. So remote counseling, telehealth counseling, those have become permanent, that the patient can be in their home and the provider can be wherever. So because what was seen, as I mentioned at the beginning, is that there was a little bit of telehealth and COVID came and there was tons of telehealth, and now there's like medium telehealth, but the vast majority of that medium telehealth these days is for behavioral health services. So Medicare, and logically, like how much physical analysis do you have to do for most behavioral health services? Obviously, there's some that require it. So Medicare is allowing and will reimburse for most mental health and substance abuse services that are provided via telehealth. There is still, however, the requirement that goes back into effect for January 1st that you occasionally need to see the patient basically within 6 months of their initial telehealth visit. You will need to see them in person, but this does provide for a little bit of flexibility that we are not seeing in the non-behavioral health world. And fortunately for FQHCs, they are allowed to serve as the distant site provider for behavioral health services. Remember, starting January 1st, they're not allowed to do that for non-behavioral health services, but for behavioral health services, FQHCs and RHCs can continue to be a distant site provider. Yeah. Oh, sorry. Also, there are some flexibilities for opioid use disorder treatment. There are the periodic assessments that are required for the opioid treatment programs can be audio only. And the OTPs may bill for the initiating service with two-way audio-visual communication. So these are just a little bit of more detail as to the types of substance abuse and behavioral health services that can continue to be provided via telehealth rather than in person. We wanted to note that all these rules we're talking about is for Medicare fee-for-service, right? So these are the Medicare fee-for-service. And while it is historically the case that other payers tend to look to Medicare for guidance as to how to implement their own payment programs, there is flexibility that allows Medicaid, the state Medicaid programs, the commercial payers, and the Medicare Advantage payers to continue to pay for these telehealth services. They might not receive funding from the federal government that would otherwise flow down to them, but they can choose to pay for telehealth services, all or none or a different subset, whatever. They have to pay for the ones that Medicare will pay for. They can choose to pay for the ones that Medicare wouldn't pay for. We think, we talked internally, we think that they're going to be really closely monitoring the impact that paying for telehealth would have on either reduced costs, as people don't run the emergency rooms anymore, or are people just saying, all right, I'll have a telehealth visit, I usually wouldn't go, so now I'm overutilizing. So I imagine that there's going to be a lot of data analysis as these other types of payers look to determine if they're going to pay for the telehealth services, even though Medicare fee-for-service might not.
So one last thing we wanted to touch on, because I know for many providers, RPM, or remote patient monitoring, has become a huge thing. And many patients are actively receiving RPM, and it has become a significant part of their treatment. So just to clarify all of these, and we've received some questions, well, what's the impact with all these changes or potential changes on RPM? And basically the answer is there aren't any. So on January 1, 2025, RPM providers are still going to be required to provide medically necessary and reasonable RPM services to established patients. You're still going to need to collect your data for 16 out of 30 days, and you're still going to need to be able to obtain patient consent either before or at the start of the RPM service. So for RPM in particular, you're not really going to see much of a change.
We have a few more questions to address, but I'm just going to take this opportunity to read the CLE code. So it is 1, 2, B as in boy, N as in Nancy, W as Wendy. Again, 1, 2, B, N, W. And again, we put in the chat a link to fill out the paperwork to get your CLEs. Also, we will be emailing you the paperwork that has to be completed, but in all that paperwork, you have to have the 1, 2, B, N, W. It is only for New York, but a lot of states accept New York. So you can take on your own, get other state CLE credits in general. Yeah, and then you have to email it back to Ivan when he'll email you and he'll tell you. Yeah. All right, so back to the other questions we might have. So the FQHC is not being permitted as distant site provider. Does this essentially mean they cannot provide telehealth services for non-behavioral? Yep, they're not going to get paid for it. I don't have much data there.
Right.
Although Part C Medicare Advantage services typically follow CMS Medicare guidance, but they are administered by commercial carriers. Have the private insurance carriers commented on audio only? No. Everyone has different policies on that. And honestly, I think everyone's holding their breath to see what Medicare will do. So we weren't able to find much guidance yet as to what anyone other than Medicare is doing.
Can you re-explain the ability of the ACOs to continue with telehealth? Is there a website for reference?
Again, the ACOs have to be accepting certain types of prospective assignment and two-sided risk. So I don't want to go into that because it's a really narrow exception. You can give us a call and we can evaluate whether your ACO qualifies for that. Those are the very mature ACOs. I don't believe it's ACO reaches or anything like that. That's the mature ACOs. During COVID, different platforms were accepted for telehealth visits, such as WhatsApp and iOS FaceTime. What is the accepted now other than EMR platform moving forward? So yes, there were waivers by HIPAA allowing for different use of platforms. Those waivers are gone. So now you have to use a secure platform. And the easiest way to know if the platform is secure is to whether it will sign a business associate agreement with you. Usually if somebody commits to complying as a business associate to the HIPAA rules, it is a platform you can use for telehealth.
So we are coming up on time to, we wanted to keep this appreciating everybody's time and, trying to keep it to the hour. So if we haven't gotten to your questions, just trying to get to that slide. Don't know where my mouse went. There we go. So if we haven't gotten to your question or you have any questions that you think about as you're reminiscing about how great this webinar is and how you feel so much smarter, because we certainly feel much smarter about after digging into this.
Yes.
Please feel free. Our contact information, you can find us on the slides. You can find us on our website. Feel free to reach out to Stacey or myself or any other GW attorney that you've worked with. We're happy to help navigate these uncertain waters over the next few weeks.
Also, I was supposed to remind you guys that This has been recording, a link to the recording will be sent out as well as the materials. So a number of you, I'm gonna get down, I think there's a couple more questions. So just so you know that the information will be sent out to everyone.
Great.
All right, thanks everybody. With that, we're going to close and feel free to reach out to us with any other questions.
Great. Thanks so much.
Thanks. Bye.